Hey everybody, John Marshall from Georgetown, the Rush Center for the Cure of GI Cancer, and I'm joined by my two co-authors on a recent paper just went out today actually on guidelines or some guidance over how best to manage colorectal cancer patients and treatment decisions during the COVID pandemic. And from the Colorectal Cancer Alliance, the Senior Director of Medical Affairs, Dr. Ronit Yarden, and my colleague and friend, Dr. Ben Weinberg from the Rush Center. And you know, you guys, we wrote this paper over last weekend, and we got it out because we wanted it urgently out for this week. NCCN has come out with some broader, I would say, guidelines as well. And I kind of wanted to go through some of our big topics for really not what to do with each move on the chessboard, but basically how to play chess. And there's some new rules here. And Ben, maybe you could get started. One of our basic principles was to decrease toxicity of our regimens. Maybe talk a little bit about that and what some of our recommendations are.
Yeah, so there are sort of two competing concerns. One is that patients who are more myelosuppressed might be more vulnerable to the virus or having worse outcomes. And there's definitely data, mostly out of China, that shows that cancer patients have a particularly high mortality rate when associated with the COVID-19 disease. However, it's a little hard to know because there's small sample sizes. These patients have other comorbidities.
And most of those patients were lung cancer patients, it turns out.
Correct.
Yeah.
Correct. So that's one issue. And then the other issue is to try to keep patients out of the emergency room in the hospital where they can get further exposed. And so for both of those reasons, trying to tweak regimens and things to try to minimize toxicity, especially myelosuppression, but also GI side effects, the nausea, vomiting, diarrhea, where patients can similarly land in the hospital for uncontrolled side effects. So to be careful about which regimens we use, how we use them, what we can do to dose reduce, dose modify, dose delay, so that we're minimizing those potential severe toxicities.
So this is like dropping the bolus, you know, maybe also the leucovorin with that, simplifying the regimens that way, you know, with a full FOLFIRINOX, FOLFOXIRI regimen, cutting back on things across the board a little bit. You know, most of our regimens, apart from that, Lonsurf TAS 102 is a little myelosuppressive, but it's also mucositis and diarrhea, this sort of thing. So what I was thinking is, you know, even if you're starting a regimen, you know, we've decided to go ahead and begin treatment, that you might do some across the board cuts on cycle 1 just to make sure they're okay. And then if you want to inch up from there, you like that kind of approach?
Yeah, no, I've definitely done that, especially in patients who I've known had issues with chemotherapy in the past, and I'm treating with palliative intent. I'm starting off on like half dose of some chemos to make sure that they don't, you know, wind up in the hospital with some side effect. And, you know, there are other groups that do lots of pharmacogenomic analyses to try to predict which patients will have severe side effects, looking at, you know, DPYD mutations, EGT1A1 mutations. Institutionally, we don't really do that as much, but I know other groups do that to try to, you know, stay a step ahead of the game. But I think just being careful and maybe, like you say, starting off at lower doses. The other thing I've been doing, which historically I've never done in the adjuvant setting, is using more Q3-week Capox, traditional Capox regimen, where we have traditionally used a funkier Capox regimen with BID dosing, but Monday through Friday, and then a lower dose of oxaliplatin, 85 every 2 weeks instead of 130 every 3 weeks. Now, to try to get patients on orals and with fewer visits, the traditional Capox regimen is looking much better, and I've been prescribing that more than I ever have.
Yeah, so this whole IV to oral thing, Ronit, I know you guys have gotten a lot of messages from patients about, you know, then is this okay? Can I switch? Dose modifications. So maybe reflect a little bit for our docs listening in about what you're hearing through your line.
Right. We are hearing patients are worried about treatment modification, if it's as good as it was supposed to be, if it will continue to save their lives. But we're also hearing a lot of them are stressed, and some of it is some of it is because of financial reasons. When switching from in-hospital inpatient treatments to at home, there are different charges, there are different liabilities, and so they are worried about that as well.
Yeah, Ben, are we getting into that with approvals if we're switching mid-course from IV to oral, this sort of thing? Has that been a burden on our infrastructure?
It is always a burden on our staff in terms of pre-approvals, pre-authorizations for orals. It hasn't been especially more difficult recently, but definitely in patients where you're trying to get an off-label oral, that can be very limiting, and a lot of those patients don't have a lot of other alternative options. And especially when we're trying to keep people out of the infusion center, out of the clinic as much as possible, that can be a rate limiting step.
Yeah. So, you know, we talk about modifying regimens. Don't not start somebody. That's important. If you think it's life, you know, it's a benefit to them, whether it's palliative or curative, we're arguing go ahead and get going, but be careful initially and work your way up instead of starting high and going down is a basic theme. You know, I'm coordinating this for our entire division, a lot of televisits. Now more than half of our outpatient visits are being done through this kind of technology. Pretty good acceptance from that, from both the staff and the patient. Ben, what's your take on that so far?
Yeah, I think overall it's been very successful, and I think patients like it a lot that they can really just get their doctor on the phone and have a discussion. I mean, we do compromise not doing the physical exam, but it's much easier. And while our clinic volumes have been down in terms of the hospital being a little bit more empty, it's actually easier for patients to get in and out. Whereas usually that, you know, what they really hate about our place is the parking lot and, you know, trying to get in. So that, even though it's better now, paradoxically, it's even easier when you can just do it from home. And I would, you know, tell patients that, you know, you should still wear a shirt to your.
I saw that. That was a very funny tweet.
Yeah, we can still see you.
But you know, I was thinking about this. I'm hoping this is sort of here to stay, even beyond, because you think about like a 80-year-old patient of ours whose daughter, it's never the son, whose daughter goes over to pick up the patient, you know, basically taking her whole day to come and bring the patient to our clinic so that we can say your CAT scan is okay. When in fact, if we could do a three-way video, it's much more efficient for everybody, quite honestly. A little bit more work for us, I would say, but the doc's feedback so far has been it's a little longer to document, a little harder to do some of that, but still serving a good purpose. So televisits, yeah, sorry.
The only concern I would say is that a lot of patients don't have access to video conferencing.
Right.
And if they're older, they don't have
the technology. Yeah.
You know, skills to do it, and that is adding another layer of stress for them.
That's really a good point. And Medicare, I think, is looking at that because we can do telephone visits, that's legal, but it's much less effective, I would say, than actually eyeballing the patient. And so you're right that we have to ultimately bridge that gap for those people who don't have, you know, ready facility with this kind of technology. And I would have to say it's nice to see people too. I mean, part of the joy of what we do for a living is that physical connection to our patients. And so I don't think it's going to replace what we do, but it will certainly help supplement. We were talking the other day, we got some of those patients who dutifully set their calendars by when it's time to have their port flushed. Pretty good data that you can spread that out. But I also wanted to talk a little bit about, you know, long course radiation versus short course radiation, and then also maybe biomarkers that can be used around treatment decision that we wouldn't necessarily say is ready for prime time, but maybe we start applying that in this setting. So Ben, what do you think about, you know, those kinds of modifications, which are not just tweaks, but actually big changes?
Yeah, I mean, the short course, long course is a really good question. I mean, there's a lot of data out of various European trials supporting the use of short course. From a patient exposure perspective, it makes a lot of sense. I mean, traditional long course chemoradiation for, you know, locally advanced rectal cancer is the patient coming for 28 sessions, and that's not something you can do at home and often not even closer to home. You actually have to physically come in for those. And potentially, you know, myelosuppression with the chemotherapy as well. And if you could do it in a short course without chemotherapy and not and straight into the time and really expedite getting to a surgery makes a lot of sense, especially in the setting of a pandemic. And that's something I think we definitely need to offer our patients. I know some institutions do that more routinely.
Yeah, so those patients that are maybe getting ready for their neoadjuvant rectal or maybe pancreas or other radiation moments, esophagus, probably we wouldn't be there for that, I think, because there's some standard recipes for pre-op esophageal, but rectal, certainly that would be in the sweet spot in the GI cancer place. And then biomarkers. I mean, we've got immune panels that can be done on tumors. We have ctDNA, which is rapidly emerging. Even one of the ctDNA companies is offering free, go to your house, draw the blood for you for follow-up. So what's your take on this? Something you'd willing to do?
Yeah, I think definitely. So the two approaches is for adjuvant colorectal cancer that we've discussed and have discussed in our review paper are one, ctDNA, which is still sort of in development. It's not exactly quite ready, I think, for prime time, but this is an era where if we can get access to it, it may actually impact what we do for our patients. So if patients have, ctDNA negative findings following a surgery, they're, we think, at lower risk of recurrence and in certain settings may not benefit as much from adjuvant chemotherapy, whereas those who are ctDNA positive postoperatively really should probably be offered some sort of adjuvant chemotherapy. The other thing I use a lot in my practice is immunoscore, which is essentially a quantitation of the number of tumor-infiltrating lymphocytes within the tumor and the tumor microenvironment. And for stage 2 cancers, if you have a high immunoscore, you really do not benefit, we think, from adjuvant chemotherapy. You behave more like a stage 1 cancer that just needs to be monitored. Whereas paradoxically in stage 3, it's the opposite. If you have a lower stage 3 cancer, traditionally, and you have a high immunoscore, you actually probably benefit from 6 months of adjuvant chemotherapy as opposed to 3. So I'm routinely sending it in those two settings to help sort of tailor what type of chemotherapy we're offering, and with the intent of trying to minimize exposure to chemotherapy if there's not going to be a survival benefit. Yeah,
I really like the way you put that, is that if they were, particularly ctDNA, if they're positive, this is somebody you really shouldn't wait on. You shouldn't sit on this. They should get adjuvant therapy. The negatives maybe make you feel a little more comfortable delaying or maybe being a little less aggressive. We don't know that one, but the positives certainly are. And then Ron, and I know you guys are really engaged in the biomarker world and doing some studies, but right. So maybe reflect a bit on that.
Yeah, we are launching on our website 2 big campaigns this month, by the end of this month. One is on biomarkers and one is on cancer monitoring using ctDNA. We feel it's very important to educate our patients on those two topics so they can be informed and have meaningful discussions with their physicians and get them to share decisions on their treatments on those topics. And so we are, we are very happy to do that for our patients.
That's great. So guys, thank you very much for both co-authoring the paper and getting on today to kind of drill down. It's in the Journal Colorectal Cancer. It just came out online tax day, April 15th, 16th. So appreciate your insights.